Thank you, Dr. Tariq Ashraf. You did it very well in time. As one comment from any one of the panelists on this very important topic. Anyone?
I think with the acute ST elevation MI, the culprit lesion should be done first. And it's not only the anatomy, but comorbidities should also be considered at that time. And the amount of contrast what you have used and the time what you have taken. All these should be considered when you are performing the primary PCI. Culprit lesion should be done, and the added lesion should be considered with all these.
Thank you very much, Sri. Now we are moving ahead to our next talk, and that is the management strategies for post-lytic and late STEMI patient. Our speaker for this talk is Professor Dr. Miqtadad Sab, and he is not here in Pakistan. From USA, we are going to take him on the Zoom link. Hand it over to Professor Dr. Miqtadad. Assalamu alaikum, sir.
Can you hear me?
Yeah.
Assalamu alaikum. Can you hear me?
Yeah.
All right. Sounds good. I'm here in Michigan about the MSU Planning Committee. Thank you very much for inviting. Let me start with this very important topic, management strategies.
Dr. Miqtadad, just wait for a minute. आपकी slides नहीं share हो रही. Just wait for a minute, जी. ये डॉक्टर कामरान बाबर की चेंज करें प्लीज. ये डॉक्टर कामरान बाबर की स्लाइड. ओके जी. जी सर.
All right. So let's start. I can't forward my slides here.
Yeah, now it is clear, ji. We can see it. Go ahead, please.
No, but I can't forward it, unfortunately. Okay. Now it's working. Yeah. So if you look at the late STEMI patients, you can see that morbidity and mortality is quite different. 30-day mortality between the latecomers and the people who present within 12 hours totally different. This is not a single study. Actually, it's been replicated on multiple occasions, and this is the Korean acute MI registry. Same thing. This blue bar represents 3-year mortality, which is much higher with the late presenters. So if you look at the STEMI patients and their timing, you can see that people who present late have, if these are the indication, a different setup with different precipitations, the ACC/AHA has different guidelines for them. But folks who present late, this is the actual cohort that we are interested in, who present very late. Does viability has any value there? Just looking at are we following the guidelines? So I'll be more to the point along these two lines. If we look at should we intervene following thrombolysis, this is a study in 1999 published, and this is where there was the era of primary PCI and different strategies were being sorted out. And the hypothesis was that if you assess these folks post APSEC, lytic, and you do angio and revascularization, does it make any difference? The 12 months mortality was actually no different, 5.8 versus 5%. The reinfarction rate was no different. There was no difference between the angina score other than placebo effect. And lastly, the ejection fraction was actually unchanged. So then came this facilitated PCI era, and that was more of a drip and shift concept. And this was the high-risk patients were being transferred to major centers for this primary PCI, and was thought that if that would make any difference. I will just put a couple of studies. ASCENT-4 was the one in which, again, lytic was used and TNK, and then they were shipped and PCI was done. There was, in fact, much higher stroke in these folks, people who received this facilitated concept. The facility PCI had 19% MACE versus 13%. Finis is another trial that was, again, retaplase was given. These are the different 3 cohorts there. And there was actually no benefit in whatsoever MACE-wise other than improvement of TIMI flow, and there was higher bleeding rate. Again, PAC trial was done. The PAC trial also showed I'm having a bit trouble with, okay. So again, this facilitated PCI PAC trial was done, and again, there's TIMI flow, which was better, but LV ejection fraction was no different. So a meta-analysis was done by Cindy Grimes at that time in JAP, and to have the broader number, mortality was actually no different other than bleeding and hemorrhagic stroke. So late PCI was actually the missed crowd. That's what we are interested in, to see if there is any difference we can make. I was also looking at what's the appropriate use criteria in these folks, and are we following the guideline? So this is a very simple example, 75-year-old patient, pain-free post-MI of 25%, past history, multiple heart attacks, and she goes up. She's a late presenter, 4 weeks after MI, and she gets this study for viability, and not much viability. The doctor tells the patient that you get maximum medical therapy. This is a typical example. These folks present to different doctors and get different opinions. So the son takes the patient to another doctor, and they say, well, you know, we need a better test for it. So they perform a FDG PET, and viability is better. So they get an angiogram, and triple vessels is diagnosed with Syntax 428. So this gentleman, this physician asked them to have a cabbage. Ejection fraction 25. Well, the family thinks that, well, it's better to get another opinion, so they get a third cardiologist who said that, well, the best thing would be low dose vitamin stress echo. They do this stress echo and looking at wall motion abnormality, and there's really no viability inferiorly. So again, the third physician gives some other opinions. The family is really confused. I'll come to this case again, but going through the viability, but just a couple of examples. This the patient received lytic therapy, having chest pain, and this is the initial ECG, 4 hours ECG, post-lytic, again, no change. So this is more of a salvage PCI. ECC is classified as 2A. Typical case, RC is revascularized, good TIMI flow. So that does have a value. So salvage PCI is a REACT trial and rescue trial, which does show that there is improved mortality and rehospitalization at the follow-up in these folks. How about this patient, 45 years old, smoker, intraposterior wall myocardial infarction, received lytic, mild chest pain, transferred to another hospital, and this is the baseline ECG. Angiogram is done, circumflex is revascularized. This is a class 2B indication. So similar cases are, they present on daily basis when we are in our clinics. 40 years old gentleman with anterior wall myocardial infarction, essentially asymptomatic, and this is the baseline ECG. Angiogram is done the next morning, tachycardia loaded. This is the angiogram, LED is totally occluded proximally. And the question is whether this stress effusion should be opened or not. Remember, this is a patient who is totally asymptomatic, and just because he's young, and what should be the right strategy. So looking at the occluded artery trial, This is a class 3 indication to open it. And I'll tell you what the reason is. Appropriate score criteria is one, and this is something that should be attempted according to the ACC guidelines, because he's totally asymptomatic. He does not have any failure. He does not have post-infarct angina. So this is the O trial, 2,201 patients, randomized 3 to 28 hour post-MI, and the event rate 18% versus 16.1% in people who are assigned to these totally occluded arteries, thinking that we will improve their prognosis. So the Adelson did a very interesting thing. His concept was that if we increase this viability zone in these folks, this peri-infarct zone, and they will increase LV ejection fraction, and they will have better effect. But there was no significant differences at 1 year in diastolic and in systolic volumes there. And this is their 5-year follow-up. In fact, there was no improvement at all. Late recanalization of infarct artery did not reduce clinical events. And I'll tell you what the reason is. So if you look at the TOSCA-2 trial, very similar trial with the hope that ejection fraction will improve. Same thing, same LV dilatation, no improvement ejection fraction. So angiographic difference did not translate into clinical difference. There was no difference in composite of head infarction or severe heart failure. So why is an open artery hypothesis not good enough? We used to think that if you open
Dr.
the
Miqtadad,
endocardial artery, that
Dr.
you were
Miqtadad,
doing...
can you hear me?
Yes.
Sir, actually your time, 10 minutes completed. You can have one more
Wonderful.
minute for the conclusion. Thank you.
Okay. So I'll finish. So in nutshell, there are different presentations of these folks, and one has to be very careful with following the guidelines, appropriate use criteria. And thank you very much. You take care.
Thank you, Dr. Miqtadad. I highly appreciate you have completed very well in time. Quick comment from Dr. Nabil, if you want to add something.
Sounds good.
I think so. It was very well covered topic. A discussion about whether we should be even opening the arteries, which we are opening in the hope that this will giving us any clinical significance or symptomatic benefit. But overall, it has to be a patient-to-patient management. If the patient is having chest pain, meaning the patient has a viable myocardium, and he needs it. But if the patient is not, the patient is asymptomatic, patient is mobile, then I don't think so. There's a very big benefit about opening those arteries just for the sake of putting a stent in, as our intervention cardiologists like to do, putting a stent in everything we see it.
Thank you very much.